because of their theory of because of antibiotic use, we don't have healthy microbiome in the gut. That's why we develop more allergies. That's one theory. And also the skin gut barrier, skin barrier system. That's also another theory. So there are multiple theories that explain the increased allergy than before.
So what are the more common foods that cause food allergy?
Most common are egg, milk, wheat, fish, shellfish, of course, peanuts, tree nuts, cashew, pistachio, walnut, those type of tree nuts as well. Those are most common allergies.
Can you explain the difference? Because a lot of people don't understand the difference between food allergy and food sensitivity. Could you explain the differences between those two?
Food allergy, I would say, like when patients eat a food and then they develop symptoms like hives, diarrhea, vomiting, difficulty breathing, cough, wheezing, then we say this patient has food allergy. And food sensitivity just means that if we do the labs or do skin tests, it shows positive. But even when they have food sensitivity, it doesn't mean that they have food allergy. We do see in clinically that when patient has eczema, they will have increased the specific IgE to a lot of food, but they can eat those food without any reaction. Then we say those patient doesn't have food allergy.
Our special guest is Dr. Yan Yan. She is a board-certified allergist with Columbia Allergy, a multi-locational allergy program on the West Coast. If you want to join us, I've just been cautioned that I hit the live button, but it really didn't go. It really didn't go live. But anyway, I think we still have plenty of questions to ask.
Okay.
I mean, I'm technologically challenged, Dr. Yan Yan, so plenty of information that we have to get to. So one of the things about food sensitivity, I think, explain the difference between lactose intolerance and allergy to milk. That kind of gives people a sense of exactly what the differences are.
Okay, well, food allergy, lactose intolerance, patients will develop, increased bowel movement, bloating, and even nausea in some patients with taking lactose-containing milk. But lactose is a sugar, is a type of sugar. If we drink lactose-free milk, we are still fine without those symptoms. So for lactose intolerance, we cannot say it's food allergy. Food allergy usually involves protein, like milk protein. If patient has milk protein, no matter it's lactose-free milk or skimmed milk, it has milk protein in it. So patient has to avoid it.
One of the things that I'm always reflecting back on, when I grew up, there didn't seem to be much in the way of information about food allergy. It was not that common to be diagnosed with food allergy. Is food allergy more common now than it used to be?
I believe so. Even in China, when I grew up, there's nobody talking about food allergy. But now with westernized lifestyle, you can see that there are increased incidence of food allergy and eczema in China, in the big city, especially the big city, not in the rural area, with cows and, sheep, those type of farm environment. So that's why we talked about, the microbiome and the hygiene theory in the previously. So if patient in the environment with more clean environment, with less bacterial or parasite infection, then the immune system start to fight with food instead of those infections. So they develop more food allergies. And especially with eczema, That's also patient has eczema, the broken skin barrier, then patient are more prone to develop food allergy as well.
All right. So once you get a suspicion of food allergy from the history, what are the techniques you use to really make the diagnosis?
We do skin prick test. We do immunocap, which is specific IgE to certain food. But most importantly, we talk to patients, ask about the symptoms after eating certain food, and also how much did they eat. Some patients maybe touching it, like peanut. Did they touch it and then they touch their face? They start to have swollen. Those patients probably have very severe peanut allergy. But if patient, they say they eat a handful of peanut, then they have a little bit hives around the mouth, nothing else, then although they might have some allergy to peanut, probably not severe. So those details in the history will help us to identify whether the patient has food allergy and how severe it is. Of course, we use the test to help us to determine whether the patient has food allergy and whether how severe it is.
What if there's a question from the history that doesn't coincide with the laboratory tests that are there? What kind of challenge situations can you set up for patients?
Well, we can do oral food challenge in clinic. We will gather the information from the history, the skin prick test, the blood test, and then if they doesn't fit with each other, then we can do oral food challenge in office. So we start with very small amount, like milligrams, and then half an hour later we start with milligrams, and then afterwards we start like 20, 30 milligrams, and then afterwards like 1,000 milligrams. So we do challenge for those patients and see if they will develop any symptoms after ingesting those food.
So once you decide that a patient has a serious reaction to foods, one of the problems that we see clinically is called anaphylaxis. Could you explain what that means and why parents should be concerned about that?
Well, anaphylaxis could be life-threatening. So if your kids do have anaphylactic symptoms after eating certain food, you have to be mindful to bring EpiPen with you, with the kids all the time. Anaphylaxis reaction, as we defined in the medical world, is that it's allergic reaction which involves two systems. So, for example, the skin could be itchy, hives, swelling, and then the respiratory symptoms could be cough, shortness of breath, swelling, throat swelling, and then GI symptoms could be vomiting, diarrhea, and anaphylaxis reaction it could evolve really quickly, and it could be life-threatening if you have severe diarrhea and projective vomiting that dehydrate, make the kid dehydrate really quickly, and then throat closing, difficult breathing. Of course, that's life-threatening as well. So anytime one patient has two system reaction, then we have to be respond really quickly, and then always have EpiPen ready, close to where you can reach for parents.
For many years as an allergist, when we identified people, especially adults who generally have problems with seafood, that's a big no-no in the African American community. If you're eating seafood and all of a sudden you're allergic to it, you're just devastated. But we were not able to do anything but tell patients, just don't eat the food. That's the solution. But now we have some more creative solutions. What are
we can do sublingual immunotherapy. We can do oral immunotherapy to desensitize patients. So basically, we introduce a very small amount, the amount that the patient is not allergic to, and then we gradually increase the dose. and then the patient will develop a tolerance. Of course, this is the process that we're gonna modify the immune system of the patient. It takes time. So after certain period of time, usually requires 6 to 9 months, every weekly visit, and then we slowly add the food each visit multiple times, and at the end the kid can reach maintenance dose, and the patient has to continue consume those food to keep the tolerance, but this is the way now we do to desensitize patients. And then, for example, for peanuts, maybe the kids have anaphylaxis reaction with like tiny bit, like a cross-contamination of the peanuts. But then after a few months, he or she is able to have 5 peanut which is amazing. And it's life-changing event. The procedure, it helps patients to not live in the fear, because parents was worried about cross-contamination, but now patient is able to eat like 5 then cross-contamination a little bit here and there wouldn't be an issue for them anymore. But those tolerance has to be maintained by using, taking those doses every day, though.
Now, what would motivate a parent? If I had my children that had food allergies, the inconvenience of having to go for these various challenges would be too much for my schedule, I would think. What are the motivations for parents who choose to do this?
Well, they want a a peaceful mind. They want to know they don't want to encounter the situation that they get call from school, or the patient is having anaphylactic reaction, patient is sending to ER, and when parents are not there, they wanted the kids be able to eat what they want to eat, so they don't get have to be isolated from the normal life other kids are living. So that's the motivation there. Safety, motivation, and also they wanted their kids to live a relatively normal life, to enjoy outdoor dining with family, with other kids as well.
Our special guest has been Dr. Yan Yan. We're talking about food allergy. We want Dr. Brooks to stay with us because I've been informed that I must not hit all the buttons right. We'll get this down pretty soon. And
okay.
He has too much good information. But let me ask you one final question. What do you tell parents about children who have exquisite food allergies about going to school and going to camp?
Well, I will tell them, depends on how severe their food allergy. If they have EpiPen, make sure they have EpiPen, one at school, one at home, and one with kids. And depends on the school environment, whether this is, for like peanut allergy patients, whether this is peanut free school or not. And also depends on their schedule, depends on their willing to whether they want to desensitize the patient or not. So we can have the discussion, see what's the best plan for them to avoid it with EpiPen in hand, or they want to desensitize their kids. There are options there.
All right, Dr. Yan, thank you so much for taking the time to join us. We may have to do this again.
Okay.
Due to my technological, how can I say it? I want to say incompetence. It's just, but anyway, so we're going to be right back with Dr. Brooks. But thank you for joining us
Sure.
in a minute. right after this break.
Okay.
I'm Dr. Michael Noor, the African American Wellness Project's health tip of the day. Well, you can tell by the wheezing and the sneezing, it's allergy season. The trees have been blooming for a few weeks, and now the grasses are getting ready to do their thing. So now is a good time for those of you with serious pollen allergy to take some action. Since it's really hard to avoid pollen, medications become the stock in trade, and there's some good ones out there. Non-sedating antihistamines like Zyrtec, Claritin, or Allegra, anti-inflammatory nasal sprays and eye drops, all of which can mitigate symptoms. And on days when the pollen counts are high, you may just have to shelter in place. For those of you who go through this year after year, now might be a good time to see an allergist. They can help you to identify triggers that you can avoid and may suggest some new methods to help you get through the season. This message is sponsored by the African American Wellness Project and blackdoctor.org. All right, so let's get back down, and I want to bring Dr. Brooks in because, like I said, we may not have gotten the valuable information. Of course, today or yesterday, the FDA or the CDC decided that we could give vaccines to children who are between the ages of 12 and 16. Are you comfortable with that?
Yes, I am, and good to be back. The decision making was made based on sound there were no deaths, there are no major side effects, what are called serious adverse events in the children. And so I am in full support of vaccinating children 12 to 15, which is the new addition.
Now, what do you say to people who would say to you, if children don't have bad disease, why should we vaccinate them?
First of all, and very low illness rate, hospitalization rate. However, if they get it, they can spread it to others. The grandkid can spread it to granddad, and he can get sick. And remember, the vaccine is for the seniors, for the adults, is anywhere from 82 to 95% effective, but 100% against serious. Because even for fully vaccinated, some getting COVID. Children around vaccinated COVID, there can be other from the children. Also, though low risk, there are children that get COVID, that get sick from COVID, and theoretically there were deaths. There were, I think, 14 deaths in the I can't remember. The 14 deaths of 14 hospitalized children, and the children they hospitalized. That
14 hospitalized children were in the placebo group, but none in the group that got the vaccine. So
exactly.
we're having a lot of little troubles today, but that just is a challenge. So I want to thank Dr. Brooks for staying with us for the full hour. I think I would get my grandchildren vaccinated. I think that the studies are sufficient to warrant that vaccinations would be helpful. We're going to face a real challenge here because vaccinations have slowed down. Those people who are resistant and hesitant to get vaccines are more and more hesitant now. And certainly when we talk about children, we really have another challenge. So we'll be here, we'll be there, we'll be giving you information. It's always timely, truthful, and transparent about those vaccines. So I'd like to thank Dr. Brooks for joining us. Dr. Yan, I'd really like to thank you for joining us on today's edition of Wellness Watch. Remember, health is your biggest asset. We will see you again next week.